while we during the course of this the presentation. It's going to take about 45 minutes. We've got some slides to go through, and Jenny will be introducing different members of her team to talk to the different slides. Then we've got a couple of videos at the end, and I'll remind you about this when we get to the end. A couple of the videos are quite quiet, so you might want to just change the device settings so you've got a little bit more volume, but certainly for Mary's video, Francis, one of Jenny's team, will actually be voicing Mary's words, so you'll be able to see Mary how she's responding to the questions, but it will be Francis herself that will be voicing her actual words. We do have someone with a visual impairment who's joining us today. So could I request that the chat function is really reserved for questions only, and try to keep general comments to a minimum, because it just helps with screen readers and so on. So without any further ado, I'm going to be handing over to Jenny and her team. I'm hoping that we are going to be joined by Pat Edkins a little bit later on, and Pat is one of our governors, and she has had quite a busy afternoon this afternoon, but hopefully when we've done all of the videos and finalised the presentation, we will be handing over to Pat. So I can see somebody's got their hand up, but unfortunately I can't. Oh, it's Chris Davison. Chris, did you want to raise something?
Well, only just to add to the welcome as lead governor for NHFT. As you can see, Fiona and I have rehearsed this. This is always going to be the thing with, as colleagues know on screen, it's not always easy. It's slightly artificial as well, isn't it? But also to extend a welcome to NHFT staff, to our colleague governors from KGH. Good to see some familiar faces like Sheila. Good to see NHFT staff here. Aaron, I can see you there. Good to see you. And also to some faces we are familiar with and those we're not. As Fiona says, this is part of our programme of membership, engagement and representation, certainly virtually, to complement what we'll be doing in person during the course of the year. So great to see everyone. Lovely to see you all. Hope you're all okay and bearing up. And thanks for giving up your time to support this event. Thank you.
Thanks, Chris. So without any further ado, I'm going to be handing over to Jenny, and Jenny will introduce her different members of her team. Tracy Davis will be driving the slides, so please, in the great style of Chris Whitty, it's just next slide, please. So I'm going to hand you over to Jenny and her team for the next 45 minutes or so. Come back briefly for the videos, and then we'll hand over to you guys for questions, and we can have a general conversation. So Jenny, over to you and your team, please.
Thank you very much, Fiona. That's lovely. Thank you for giving us the opportunity to talk about dementia in Dementia Action Week. And we'd like to raise a profile of the younger people's team. It's a lesser known service, I think, than mainly dementia seen as an older person's service. But we're one of the young people's teams, and I'm just going to talk to you and the rest of my colleagues, my lovely team, all with me. We're all going to talk about what we do within the team. So we'll give you an overview of our team, how it works, how to access the services in Northamptonshire. Okay, so next slide. Thank you. So who are we? We're known as the early onset team, we're younger persons with dementia team, we're young people with dementia team, but we all do the same thing. So we work, sorry, I'm going to do the slide backwards. We work with people under the age of 65. And we get referrals from everywhere, GPs, different teams, other services. So we're a county-wide service, and that means we cover the whole of Northamptonshire. So anyone with a GP, anyone that attends a GP surgery in Northamptonshire, we will accept the referral from them. And sometimes that means we cross borders. You know, we work in people with Rugby, Leicester, all sorts of places, even been to London as well. So our team, it's a very small team, and we do cover a really large area. So there's 3 nurses, me being one of them. There's a support worker, an occupational therapist, a neuropsychologist, and 2 assistant psychologists. And they will be introducing themselves as they go through the different slides. Next slide, please. So in Northamptonshire, for the last 18 months, we've had 417 referrals. And we are one of the only services really that offers the service that follows people right through from the beginning to the sort of latter stages. So there are as little as 13 services that offer support for young people with dementia. And some of these services are only support based, and a few offer both assessment and support. So we do it all. So if we get a referral, we'll do the whole assessment, diagnosing and support. So our team offers a range of assessments, support, one-to-one intervention for carers and service users, informative and therapeutic groups for carers and service users, and opportunities to connect with others going through a similar experience. Next slide, please. So what is dementia? Dementia is an umbrella term for a range of progressive conditions that affect the brain. Each type of dementia stops a person's brain cells, neurons, working properly in specific areas, affecting their ability to remember, think and speak. Doctors typically use the word dementia to describe common symptoms such as memory loss, confusion and problems with speech and understanding. That gets worse over time. Next slide, please. Next slide, please.
The slides got stuck, Tracy. Oh, there we go. Thank you.
Okay.
Back to you, Jenny.
Sorry, it was a bit sticky there.
No, that's fine. So I'm not going to go into all the signs and symptoms, but there's a few of them, and I'll read a couple of them out. So people can become repetitive. They can ask the same question over and over again. People can stop understanding. They lose the ability to process information. So that means that they can understand a little of what's being said, but not all of it. So there's processes that go all the way through when we're given a task, so to speak, and a person can understand parts of that, but not all of it. So they tend to miss bits. There's people can get lost. In familiar neighbourhoods, they get lost on the way home or when they're going to the shops. They can use unusual words to refer to familiar objects. And people can change in their emotions. People could become less emotional or more emotional. And it can be a loss of daily activities or having an interest in things. So next slide, please. And this is Emma now. Emma's one of the nurses.
So I'm Emma, one of the community psychiatric nurses in the team. So just to give an overview, obviously we're talking mainly about the YPD team today, but also we have an older adult service for people over 65. So again, they would take referrals from the GP in acute hospitals. There's a Kettering Corby team and a Daventry Northants team. So what would usually happen is that a nurse will complete the assessment, feedback the assessment to the wider team, and if someone is diagnosed and given medication, they will continue to be seen in memory monitoring clinic. And if there's no medication, it's usual they might be discharged back to the GP. Everybody will be offered the opportunity to access the hub and be supported by third sector groups at Alzheimer Society and Northamptonshire Carers. So again, they will be offered groups that's offered by the trust as well. Next slide, please. So for our service, like Jenny said, we work with people under the age of 65. So what we do ask for our pathways that people have been seen by their GP first, and we ask that they do some bloods that look at reversible causes to explore things like thyroid or vitamin B12 and folate and things that might be reversible because they can impact on people's cognition. We also request that the GP completes a sort of mental state exam and mini memory test in the GP clinic first. So once that sort of pathway has been followed, if they think that it's nothing that's reversible or can be treated, then they will refer on to us to do some further assessment. So we take referrals really from everywhere, and once someone's been seen by our service, if we discharge and they feel later on there's a change, they can self-refer directly back to us rather than having to go back through the GP again. Next slide, please. So young onset dementia is obviously young onset of symptoms before the age of 65. As Jenny said, people often associate dementia with people, older adults. Some of the common presentations are memory complaints, depression, behaviour changes and physical symptoms. Dementia can be more difficult to diagnose in the younger adult. Often it can be thought of it as a depression presentation at first, and often people aren't used to seeing people presenting in GP clinics with young onset dementia. So obviously it's not the first thing that GPs will often think of, is this a dementia presentation? Often as well, people don't always go to see the GP about memory concerns because they're frightened or scared of stigma and things like that, so they don't often go. So sometimes we can get people quite far down their journey that come to us that may have been presenting with symptoms for quite some time. Next slide, please.
Okay. My name's Nina. I'm one of the nurses with the team as well. So I'm just going to have go through some of the different dementias that we quite typically see as a rule, and just to explain some of the signs and symptoms of them. So we've got Alzheimer's disease. So this is obviously caused by an abnormal build-up of proteins, as Jenny said previously. And some of these signs and symptoms can be the inability to learn new skills, word finding difficulties quite often, and problems with reading and writing and processing numbers, working with numbers. They obviously memory loss and confusion as well, and poor attention span, really. I mean, there are others because everyone's an individual, but these are some of the signs. Then we've also got vascular dementia, and this is caused when there's a decreased blood flow, and it damages the brain tissues, or completely blocks the brain tissues. And again, these symptoms can include confusion, slower thinking process, and some changes in behaviour. With the vascular dementia, we obviously encourage a healthy lifestyle because they've got managing physical health problems such as heart disease or high blood pressure, anything that could increase any vascular risks. We try to manage and maintain just to help slow down the process a little bit. We've also got mixed dementia. So Alzheimer's and vascular are the more common types of dementia. And this is when there are two types of dementia that occur within the brain. But you can get other types as well. So you can get Alzheimer's with Lewy body, for example. So we're just looking at the different functions of the brain and seeing which part of it is affected. And this is more where the mixed dementia might come into it. There's frontotemporal dementia, also known as Pick's disease or frontal lobe dementia, or FTD, you might have heard as well. This happens when the frontal and the temporal lobes are damaged. So there are 3 different variants or types of frontotemporal dementia. So we've got the behavioural variant. So as Jenny was saying before, that can affect the behaviour first. You know, people can prevent as with lack of motivation or interest, empathy, maybe inhibitions. You know, they can become quite obsessive sometimes with some of their behaviour, quite compulsive as well. Occasionally it can change the appetite and they can crave more starchy or sweet food. So we look at all of these areas. Then we've got progressive nonfluent aphasia. This is where people can have difficulty with speech. So this can be that they might be mispronouncing words or stuttering, having difficulties with complex sentences. And you've got semantic dementia as well, and these all fall under. And this is where people might be able to say words correctly, but have difficulty with vocabulary and understanding what objects are. So as Jenny said earlier, they might have a fork, but they might not be able to say what the name of that fork is, for example. or if, you know, they're trying to describe, they can't think of the word of an object, they're having to describe around it. So they know what it is, but they can't think of that actual word. Then we've got, we get quite a few as well, alcohol related dementias. So you've got vernix and encephalopathy. So this is a response to a lack of thiamine deficiency, and quite often this will present itself with people with involuntary movements, eye movements, quite rapid, but this can be treated, or with the right detox and thiamine. Normally some of the confusion can resolve, and obviously without drinking any further, to prevent any further brain damage as a rule. Then we've got Korsakoff's. Sorry, I know it's a lot of information that I'm throwing at you here. You've got Korsakoff's dementia, and again that presents very, very similar to the vernix, but it is the dementia, the damage has been done and it is progressive. So you've got the alcohol related ones. We've got Lewy body dementia, and this is caused by very small clumps of abnormal proteins that build up within the brain cells, and because of their shape. And this can again present quite similarly to Alzheimer's disease with the confusion, but it can also have some Parkinsonian traits, so the slowed down movement, the shuffling gait. People can have very vivid dreams and act out on them, experience visual hallucination or delusional thoughts with it, and it can vary very much day to day how it presents. And yes, yeah. And then we've got one of the ones which maybe a bit lesser, posterior cortical atrophy. So this is where symptoms are consistent with damage to the posterior cortex of the brain, and this is responsible for the vision. So this can affect difficulties with visual tasks, so not being able to read the line of a text, or not be able to see an object clearly, so they might have to get up to move to see the object. Difficulty with spatial awareness, distinguishing objects, but it can present very differently to each person, and that can also people can also experience hallucinations with this as well. And then there's Parkinson's disease dementia. So this is this is given when somebody has a diagnosis of Parkinson's. And it is again a decline in thinking and reasoning skills, and the symptoms are often again problems with concentration, memory, and interpreting visual information. But again, they have to have a diagnosis of normally Parkinson's for at least a year or so, they roughly say. And then we've got Huntington's disease, and this is a genetic disorder condition. And this can cause dementia, and again it can slow down the progress, the movement, memory, thinking, emotional state. Quite often people can remember, so it's a bit different to Alzheimer's in the fact that they can have very good memory of recent events, but it will affect things like not necessarily recognizing people or places, and yeah, sorry. But also one that we haven't put on there, so apologies, but I just want to quickly say is that we obviously see people with the less common sort of dementias, so which are the genetic conditioned ones, so familial Alzheimer's and familial frontotemporal dementia, and that's where this is a genetic, so it's inherited, and we would normally have to, or we would refer to London as well, and we'd have to look into we could look into genetic testing. So yes, I think that's okay. All right, next slide.
Okay, so during the assessment process, what we do as a team, we look at what the actual concerns are, how long the memory problems have been going on for. It may not necessarily be a memory problem. If it's a frontal temporal presentation, it's not necessarily the memory that's the first thing that changes. It can be people's personality. They can be doing unusual things. It can be lots of things. So the history that we take is really crucial. So we all have got really good assessment skills, I have to say that, but I do think we have got good assessment skills as a team. So then we look at the social and personal history. So as Nina has said, sometimes we do come across the familial types, and therefore that would suggest that another member of the family's had the condition and their families had it. So it goes on. So we'd look at that and we take a good history, and that goes towards the actual assessment process. We look at the family medical history, and if there's been a change in people's abilities to function. So basically, if it's people are finding it difficult to drive, navigate, find their ways around. I'm not going to go into that too much though, because my colleague Francis will be discussing that later. Emma?
Okay, yeah. Our assessment can be quite lengthy. We do say to people to have people to support them if they'd like to, so a family member, friend, because sometimes our assessment process can take up to 2 hours. That's not always the case, but we, like Jenny said, we like to make sure we get an extensive history to look at, making sure that we can rule out that it's not something else other than a dementia. So part of that also includes a mental state exam. So we'll be talking about people's mental health, what their current mood is like, anxiety, are they eating and sleeping okay, all things that do impact on people's concentration and cognition. Like Nina's already said, we do look at a drug and alcohol history because of the damage that that can cause to the brain. So again, it's important that we know that, you know, people's usage is, and again, that we can link them in with the appropriate services for support with that. We also look at medical and psychiatric history, again, just to make sure there's nothing physical that's going on that could be treated and reverse the symptoms. And then at the end of all that, when we've asked them 1,000,001 questions, we complete a cognitive exam, and we use the Addenbrooke's ASAR that we go through with them. So they've probably already done a mental state exam, a cognitive exam, sorry, rather, with the GP, but ours is similar, but just a little bit more lengthy. And we would repeat them 6 monthly if we had concerns that, you know, we weren't quite sure, we'd need to repeat that. We'd leave a gap of 6 months usually before repeating that with anybody else. So that's kind of what to expect in our assessment. Next slide, please.
Hello, my name's Frances Hooper and I'm the occupational therapist within the team. So as Emma and Jenny have said, our initial assessments do include questions about people's functional ability and things like if they're still working, whether there have been any problems that they're encountering at work. As Jenny said, things like driving or domestic activities, if there's been a change, and that's usually with the person themselves, but also with the family, because sometimes family pick up on things or subtly let you know that they've noticed changes. So if there are concerns and perhaps they've scored lower on the cognitive assessment, or there is an indication that there could be a dementia, then they're usually referred for a more detailed functional assessment with occupational therapy. So this will include a much more detailed interview with the person and relevant family members about their usual routines. Particular things to flag up is perhaps if there's something that they've always done which is now becoming a lot more difficult, or perhaps occupational health might have got involved in their work role if they're struggling to do their job. So we'll certainly get that detailed history, but usually where possible do some actual practical observations of people participating in activities, and that includes unfamiliar tasks, because people might be able to manage still quite well with routine familiar things, but doing something that's new will highlight if there's a problem with what we call executive functioning, things like problem solving, or it can highlight perhaps if there's a visual problem, like Nina referred to the post-cortical atrophy. Sometimes it's only when you actually see somebody do something practical, it might highlight something that you wouldn't pick up on verbally. So that might be done in one visit, or it might be done over the course of time. And the initial involvement is as far as the assessment, but it's also later down the line looking at adapting, changing things to enable people to be as involved as possible in their usual activities and their roles, or finding new ones if there are losses that they've had to come to terms with. And also if there are changes in mood and behaviour, looking at other things that they can do that are rewarding and positive for them. Next slide, please.
Hi, I'm Hina. I'm the senior assistant psychologist working with the YPD team. So I'm going to kind of speak about what the role of psychology is within the younger people with dementia team. So I'm going to start with explaining what neuropsychology is, and it is a science concerned with understanding the relationship between the human brain and our behaviour. So, for example, if someone had sustained an injury to their brain or neck, they may experience changes in their cognition, and that will be shown through, for example, their memory may worsen, and they may not be able to think as clearly as usual, or you may see changes in their emotions, so they might become more anxious or low in mood, or in their behaviour. So someone who is a very loud and outgoing person may become very flat and quiet. And in the diagram on the right, there are different areas highlighted in the brain. I'm not going to go through all of them because I can't pronounce all of those words, even with years of practice. But they basically show that different parts of the brain, so for example, the frontal lobe it is in control of your thinking and planning. So if a dementia or an injury was sustained in that area, it would affect those kind of skills, and it's very different for everyone. So a tiny part of your frontal lobe could be affected in one person. It could be exact same damage in someone else, but the changes in these people can be completely different because it depends on a number of different factors. But that gives an idea of what we are looking at, and sometimes we ask for scans, an MRI scan, to give us some more information, and then we can discuss that with our results of assessments as well, and I'll go through that in the next slide, please. So our role comes in, so after a person has been referred and has had an assessment with the team, they may be referred to psychology for more complex assessments. So as Emma said, they take part in a short cognitive assessment called the Addenbrooke's Cognitive Examination. So we'd look at those results and we'd then take on a further assessment. So that could be a range of different things. So if they were didn't score so well in memory, for example, or executive functioning, we'd look at those areas a bit more and take a more detailed assessment instead. And we'd put all those results together, score them and discuss them with the team. So we'd come back and say, this is what we found, and decide whether they need another assessment in 6 months' time to identify if there is a decline, for example, or we might say that, oh, this is very clear, and they may have a diagnosis and it matches up with the initial assessment results. Or we may ask Francis to come in and do a functional assessment if one's not already been done, or we might refer for a scan if we haven't already, to kind of just piece everything together before making a decision. So that is how our assessments work with psychology. And if we go to the next slide, I'll explain how we lead for intervention. Oh, sorry, you already changed it. That's because they look
I thought I hadn't done that then.
Just keeping us on our toes there, Hina, because I was thinking, I'm sure that slide has changed, but fine, back over to you.
So if there's been an appointment, a general appointment with one of the care coordinators, we may pick up on something that a carer or a patient might want additional support. That will come back to our team meeting and we'll discuss that, and a referral to psychology can be made. So then we would discuss what that referral was for. So, for example, someone's husband is not coping so well with his wife's changes. We may discuss the referral for carer support. So then what we do is make an initial appointment with said husband to identify the goals of what they want and to identify what intervention type would be helpful. So, for example, if they wanted help but they didn't want to engage in something, then that would be quite difficult. Or if they were all for intervention on a weekly basis, then we would try that. Again, though, our service is not to give that continuous support with that intervention. We like to see a pre and a post change. So, for example, for carers, we offer something called START, and that would be an 8-week program to help them build skills to cope with the changes that they're facing on a daily basis, to give them work to take home and apply to real life. And we really try and tailor that to the individual person so it relates to what they're going through, because like I said, everyone is completely different with their diagnosis and their family life. And again, with younger people with dementia, we have to think about children and jobs and not having the ability to drive anymore. So it is really quite tailored. And then at the end of that, we would review if their goals were achieved from that, if their mood had been improved, and if they were using those skills and they were helping. And then we'd ask them to offer some feedback from a feedback form and to evaluate the support that's been offered. So that's just one example of the intervention that we offer. We do offer more in terms of groups, which we'll go on to in a second, but Frances is going to step in with the next slide. So when you're ready, thank you.
Thank you. So I think, as Hina's just referred to there, really, I think the impact for anybody to have a dementia diagnosis is huge, but for somebody of a younger age, it can be particularly challenging because these may be people still working with young families, mortgage to pay, and also role reversals. So often one partner might have to sort of take on new things that they've not had to do before, almost like a bereavement, really, and the other person adjusting to that. So, and that's why, as Jenny said, we do remain involved throughout, as long as people need our support. So that involves things like understanding the diagnosis and answering questions about prognosis. For some people, for example, with Alzheimer's, there may be an option for some medication, cognitive enhancers, which can, for some people, help with slowing down the progression of symptoms. And if that's the case, then the nurses will arrange for that to be prescribed. We collaborate with a consultant, and they will supervise the first 3 months and monitor the person, and then hand that over to the GP. We look at legal things like power of attorney, benefits, thinking about advanced care planning, supporting people to sort of start to try and make those decisions early, whilst they have the capacity to do so if they do. As I said earlier, it might be looking at things like aids and adaptations within the home to enable people to be independent as possible, and linking in with other support services and organisations and social services. So things like assistive technology for safety and reminder equipment, might be community occupational therapy in the home. And we liaise quite a lot and refer a lot of people to social services for care packages. So we're trying to sort of improve the understanding on both sides of services to have for that to be more streamlined. As Hina's already mentioned, there's also specific psychological support which can be one-to-one, but also we do that in a group format. And I think the key thing really is trying to support people to live well with dementias, that see that there is a life beyond the diagnosis once they've had to cope with receiving that, but both for the person and for their family members. Next slide, please.
Thank you, Frances. So I'm going to go through some of the groups that we offer, kind of just like an overview. So one of the first groups that we would offer, which we literally a couple of weeks ago we did, is a post-diagnostic workshop, and that is for our service users and family members and carers. And what that workshop is a one-off for newly diagnosed service users to attend and to get a better idea of what our service is and what we do to support them, so they're aware. And I guess the important part is that they don't have to take interest or take part straight away, but just know that we offer that, and when they are ready that we will be there. And it's an opportunity for family members and carers as well to interact with other people. I know from a lot of our groups there are family members that walk away and they go for a coffee together, or they just have the opportunity, say that person's in a similar situation to me and they know what I'm talking about, and I think that's really special to see. So that's what our Next Steps workshop is about. And then from there we have two groups designed for service users. So it's kind of split to a higher functioning and a bit lower functioning. So our Living Well with Dementia is more for people with a high functioning cognition level, and that again is supporting them to live well with dementia, to take part in activities, to give them an idea of what it is that they are going through, offer them ideas of memory aids and strategies that they can implement in their home and what works well for them, staying active, and memory and stress. So loads of different topics that we cover And then with cognitive stimulation therapy, a little bit similar, but mostly for a slightly lower cognition level. So it's mostly activity based. So each week there's a different theme. So it could be, for example, one week might be on childhood. So that's quite nice because people are asked to bring a memory of their childhood or a favourite place that they used to visit. Think about, I don't know, the seaside, for example, and that just brings up a lot of conversations and people get really animated and happy. And it's quite nice to see that, you know, they're living in that moment again. And just by bringing that conversation up, that we've brought all those memories back for them. And again, there's no pressure with these groups. It really is quite patient-led sometimes, and it's nice to see that happen. Even though there is a structure, it is really it's important to see where the passion comes through with our service users. Next slide, please. So then we also have some more groups. I know Francis is also starting a sensory group, which is not on here. So that is for even lower functioning, so people that may be not able to communicate verbally as much, but trying to, hopefully I'll pin back to Francis in a second to give us a bit more information. But we have peer and family events. So we've had walks in the past. So for example, Stannick Lakes, again, opportunity for people to connect. We've had times where some of us have walked away with service users, leaving family and carers to have their own time as well. And the team just engaged in the Wendell Walk at the weekend, and that was a huge success. The photos are brilliant. It's so nice to see. It was a fairly large group, though I did hear they got lost, but they got their medals, so that was very positive. And then we have a space for a peer support group and a family support group. So our peer support group is for our service users, and that's currently online at the moment. We have a good turnout, and again, it's very much service user led. And it's, again, just nice to see people share their experiences, what they're going through, and give each other advice and feedback. And we have a topic to talk about. So, for example, Easter and what everyone did. And then before you know it, it's taken away and we kind of have to say, oh, it's time's up now. But you don't almost want to say that, but it's really nice. And again, with our family support groups, so for carers to join online, and sometimes carers ask for specific topics, so benefits or advanced care planning and things like that. And we will try our best to tailor to each session. And again, if it is being led in their way, then we'll give them that space to connect and opportunity to do that. I'm just going to ask Francis to explain a bit more about sensory workshop.
I will do, and a couple of other things if we can.
Okay, yeah, of course.
Yeah. So yes, I think we wanted our groups to reflect the sort of changing needs of the people that we support. So people that are more advanced in their dementia, we're going to be doing some sensory workshops which introduce a sensory approach, and the idea is that it gives the skills and a bit of an assessment to then hand back to those caring for them and living with them, things that they can try, because people will often say, well, I've tried to get jigsaws and do this, but what would work? So that just gives a bit more opportunity to do that. And people, I'm sure, might have seen themselves, things like people's reaction to music can just be such a lovely connection, and people can suddenly sort of come back to life. And another one that I'm hoping to develop is looking at life story work as well. But what I didn't say earlier is one of the things we do is try and connect people to the services that exist in the voluntary sector, so the Alzheimer Society, Northamptonshire Carers. And I think sometimes in the past we've had feedback that people we support go along and then they feel a bit alienated because maybe there's 10-15 year gap or more, and some of the activities are maybe more focused on people who are older. But I know the services are very keen to make themselves relevant for the people we support, and we've got some people that just recently joined Memory Matters with Alzheimer Society and brought the age range down, so that's been really positive. And I think somebody mentioned something called the Hub earlier, and just to explain for those that might not have heard of that, that's quite an exciting project really, which in the end will have 8 dementia hubs across the county with the services that I've mentioned, and also NHFT and our services sort of connected together, providing support. And that was piloted in Corby, and there's now one in Northampton at St Crispin's Community Centre. And we've got one of our groups, the Cognitive Stimulation Therapy group, is going to be starting, hopefully if we can get everyone ready by next week in that hub. And one more group that we've just recently developed is the service user involvement group. So meeting regularly to help the people we support actually shape the services, getting their feedback on things like leaflets we produce, helping them to identify things that they want to reach out to. A lot of them want to actually educate people about dementia and that you can live well with dementia. So that's something that we started to do and try to reimburse people for their involvement as well. So again, they don't particularly want a monetary reward, but just feeling valuable, valued, and having skills and things to offer can be very therapeutic. So that's been a really positive thing. So next slide, please.
So reflecting on our, sorry, I need my glasses. Sorry, reflecting on our service. So we was asked to talk about some of the successes and some of the challenges. So if I start with the successes, working through the pandemic and adapting, i.e. online groups. Now I can't take any thanks for any of this. This was done purely by my colleagues and I just followed along because I'm not IT savvy. But I have to say I was really proud that we didn't stop seeing people through the pandemic. We obviously did home visits as well if we had to, because obviously there's a risk. Young people live on their own as well. So, you know, because of the pandemic, people's illness just didn't stop. So we continued our service. But I was most proud really that Francis was able to develop online groups as well. So everything really continued in a slightly different way through the pandemic. So opportunities for our service users to connect, i.e. peer support groups, carers groups and everything else, that is really positive. We have some really good feedback and it's great to be going out and seeing people again and mixing with people. We've done lots of things in, you know, with, like Hina said, we've arranged walks and all sorts of things and they really are good. Positive feedback from our service users and their families. We have this form in the trust, I want great care. So we do get quite a lot of good positive feedback. Oh yeah, as Hina said as well, a range of events for the team, service users and families to connect and promote dementia awareness in under 65s. We did the Wonder Walk, me being one of them. I'm not going to accept any responsibility for us getting lost because I was just following everyone else. And we've also got some stalls that are actually in Rushden Library, as this is where we're based. One's going on now and I think there's another one Thursday morning as well. So some of the challenges obviously are we are a county-wide service. It makes it difficult. We tend to try to see people in their homes as much as we can. We do have clinics. We do try to accommodate people's needs. Obviously, it's not easy for everyone to get to a clinic, so we'll go and see them at home, or we'll meet in GP surgeries wherever people feel comfortable. It's difficult to find, you know, areas where we can have groups in because obviously Daventry, Northampton, everywhere, if people are not able to drive anymore, travelling become an issue. The last cognitive stimulation therapy group was in Rushden, and the next, as Francis said, is planned for Northampton, which starts next Thursday. Trying to support our service users with the loss of their jobs, ability to drive and look after young children. It can be incredibly difficult to do these things. Obviously, as Francis said, there's a loss of role as well. You know, financially, people start to struggle. We work really hard to encompass everything that people may be going through. So we look at their benefits, we try to help them apply for benefits, power of attorney, all those things that Francis said. So it can be quite stressful and there's only a few of us and we cover a large area. So that within itself can be difficult, but it's a good team, it's a strong team and we try our best to look after people. So next slide, please.
So do you want to introduce it?
So it looks like we're ready for our service user videos now. So I'm gonna, so I didn't even have to ask Tracy to take the slides down. So we are going to, Hina is going to be displaying the videos for us. These only last about 5 minutes. The first video, the volume's okay on the first video. We have increased the volume where we can. The second video with Mary first video is with Alex. The second video is Mary. It's a little bit difficult to hear. So Francis will voice Mary's words, and then we'll come back and we'll just gather together again, full screen as we are now. So without any further ado, over to Hina for the videos, please. So I might be having a technical hitch there. Oh, here we go.
When I was first diagnosed, it was a little upsetting, and I think I actually cried a little.
We're just going to start it again because it seems to have been lagging.
Okay.
When I was first diagnosed, it was a little upsetting, and I think I actually cried a little. But then the more I thought about it and the more time that passed, I become more comfortable with the idea. It was a bit worrying. It was difficult for Beth, my wife, but in the end, we've come to terms with it. As I say, we know exactly what I need to do, and we try to balance our life around it.
It was a great shock when I first got the
Diagnosis, it made me feel a bit useless.
diagnosis of
I'd always
dementia.
worked all my life.
Because I'd always worked all my life, and it kind of made you feel a bit useless.
It made me feel a bit
I knew
useless.
something was wrong.
I knew something was wrong.
Because
been
I began
Getting lost, going to work, and finding my work
finding my job
in the prison service
was
more and more difficult.
And then my son suggested.
Then my son suggested I went for a driving assessment.
A test at the vehicle licensing place.
And I failed the test.
And, I failed the test.
After that, I had to sell my car. That was a big loss.
Sell my car, and that was a big loss. Also, I felt guilty about
it
diagnosis because
and how it would affect my children.
My children.
Since my diagnosis, I was offered the opportunity to join in some groups online, and I found that very helpful. The opportunity to meet other people gave me an opportunity to understand all about my illness, and I found that basically it was so much better that you as a team give you an ongoing relationship.
The memory clinic have been really
The
good.
memory clinic have been really good and gone out of their way to help. What has helped after diagnosis? Well, my sons have bought me a bike.
My sons bought me a bike.
I cycle down to Animals in Need, where I walk the dogs. That gives me a purpose.
Walk the dogs, so it's given me a purpose.
I don't have to rely on anyone. I can do it on my own. And the dogs enjoy it, and I enjoy it, and it keeps me fit.
Since my diagnosis and having yourself and other members of the team visit and seeing people at the group meetings and the staff, it's opened my eyes to a world of possibilities that I'd sort of given up on the idea of my life being so fulfilled. But it's so important for me to have the group, the monthly meetings that I have with you, and because it's someone to talk to who understands my condition and the way things are for me now. I think if it hadn't been for the group and everything else, well, before the diagnosis, I could get into really dark places, really dark places. But now I don't have those thoughts anymore, and I look forward to my life and with endless possibilities.
One of the best things
was meeting other people in the same situation, because you do kind of feel a bit different when you've got dementia. It's nice to be able to talk to people and laugh about it as well.
After my diagnosis, the one thing that surprised me the most was how different I was to my perception of what dementia was. My idea of dementia was, my dad was sort of in his 80s, he was taken ill, and then suddenly he was put in a home, and you know, there was nothing, whereas I've got dementia, but I still am functioning. I still do all the things that I want to do now, and it's just so different. But I wouldn't have had that opportunity to see how it is for all of us without the team, basically.
I decided that life was too short to bother with duvets.
I used to get tangled up in them, spend about an hour trying to get the duvet cover on.
So I turned to blankets,
and that took a lot of stress away from me.
The challenge has been dealing with my anxieties. If I try to do things I don't know, it agitates me, and if I try to go places where I don't know, it agitates me. What the team has done is encouraged me to carry on and to do those things, and gradually you sort of develop a way of dealing with them for yourself. I'm now doing more than I was, and I think that's in part thanks to the group and the opportunity to meet other people. Seeing their challenges helps you to improve yourself. I think you have to remain positive, keep yourself active.
Brilliant. So thank you very much. So if Pina can just take that video down, that's brilliant. So we should all be back in the room. So before I open the floor to anybody with any questions, I just wanted to say an absolutely huge thank you for such a really informative presentation. It was so smooth. Your passion and your experience and your knowledge of the subject absolutely shines through, and you're such a responsive team. I'm really very impressed, and certainly you've set an incredibly high bar for the next membership events that we have. So I just wanted to say a huge thank you, and if we can perhaps give the team a little round of applause for doing such a really great informative job, and just debunking some of these things that we hear about dementia. So I just wanted to say thank you for that. Now, we have got about half an hour, and the team are here to answer any questions that you might have. I can see that some hands are going up already. So I'll do my best to actually introduce people to actually come in and ask questions. Now, if we We obviously won't be able to necessarily talk about individual cases or individual circumstances. We might not be able to answer all of your questions, and if we can't, we'll let you know and we'll come back to you. But really, the floor is yours now. And I'm just gonna, before I start, I'm just gonna ask Tracy, because Tracy is one of the organising team, and I just want to make sure, Tracy, is it a technical thing that you just need to alert us to?
No, it's an actual question.
Okay, brilliant. Oh, fantastic, even better. So I'll come to you in the order of the questions. So without any further ado, can we have Sheila with the first question or comment, please?
Yes, it's a question actually on a personal level, because a very dear friend of mine has the frontal pit disease, whatever I don't know what it's called, a disease, but there. Unfortunately, I don't live near her anymore. She's a friend from my days in Cornwall, very intelligent, brilliant lawyer, who I first met when I went for some legal advice, and her mother had just died, and she adopted me as her surrogate mum. And so I've known her for a long time. And the changes in her behaviour when I saw her, because I got back down to Cornwall as often as I could to see her, were quite remarkable. And she'd forget things like where to put the washing liquid and where to put the rinse in her washing machine. And she wasn't good at holding telephone, and her television was a complete mystery. I was not allowed to touch it because she knew exactly how to do it, which was quite good. But got very cross with me one day because I turned it on to watch a current programme, and she only watches the ones she'd recorded. And obviously what she managed. So it sort of unravelled a lot of the mystery. Unfortunately, I don't get to speak to her anymore. She has a full-time carer now, and she's unable to speak on the telephone. And a mutual friend who lives in Willen, near Milton Keynes, and I do phone another mutual friend to find news of her, but that's as close as we get. I don't think there was any history of this in her family, so I just sort of wondered, is it a random thing, or does it have one particular thing that triggers?
Jenny, can I perhaps, if you start with that, please, or one of your team?
Okay. Does anyone want to answer that, or no? It'd be me.
You can. Genetic.
Yeah, there is a genetic frontotemporal gene. However, it's quite low, so it doesn't have to be genetic. And with the younger people, we find that that's more often diagnosed than it is with the older people. As for reasons why, Sheila, I don't know. It's just it's the same as any other dementia. Unfortunately, it's just one of those things that happens, really. I mean, they're doing research into it all the time, aren't they? But I don't really know if there's any particular answers for that, really.
Sometimes it's the area of the brain that's damaged.
Yeah.
So even if someone's had some vascular changes, that might have affected
The frontal
area,
area, yeah.
and then that's what displays those symptoms. So,
Yeah.
you know,
So it's where the atrophy is, as Emma said, or the changes in the brain, and that's what will show. That's what the effect will be.
Yeah. Yes, I mean, I do begin to understand more, because it was going on for some time, I think, slight changes I found in her behaviour over the years before she actually got quite,
And that's one of the things with a frontal change. It can affect people's behaviour. It can affect those social inhibitions, you know, where we think something but we won't say it, and that's what happens. Those are all the things that change, really. And it can take quite a while to diagnose. It's not a straightforward memory problem. So, as Emma said, when people go to the GP, if there's concerns in that, and there's nothing wrong with your memory, particularly with a frontal presentation, not to start with. So it's all the other things, and it's not necessarily picked up that quickly, unfortunately.
it was problems with her speech that was the beginning of it.
Right. Okay. Okay. Yeah.
Thank you anyway.
No,
You know,
pleasure.
it's answered some questions, and you will understand. It opens up a lot more.
Thank you, Sheila. Rashmi, can I perhaps come to you next, please?
Yes, can you hear me?
Can hear you
Yes,
perfectly.
yes.
Yeah,
You
yeah.
fire away.
Very good presentation, really, interesting. And I think it made me thinking, because I had my mom who passed away in 20, she had a dementia and I supported her. But her dementia was to do with classed as senile, which you haven't included, but she had a lot of the similar, some to do with memory, to do with moods, to do with, getting lost, unable to do things and all that. So I just wonder. And again, one of her sister in India, she had the same sort of situation. But so I just wonder again, likewise, whether this can be as a genetic, and this as I say, so how this relates to all the other which you didn't mention to it. And I also wanted to add another question, especially because in terms of language, we had a great difficulty. Mom couldn't speak English or what have you, so there was nothing in terms of language. I had to be there as a carer, support, interpreter, everything. So within your team, how do you or could you address, and also within, is there any statistics within Asian people, young people, older people, how they supported groups, anything? All that. I know too many questions, but anyway, see whether you could address it. Thank you very much.
Let's see if we can start to answer a couple of those. I think Jenny and her team, I'm sure, will be able to give you some feedback. So over to Jenny and the team.
Emma?
We do, we are aware of different backgrounds, and we can get the Addenbrook's cognitive test in different languages. So where we can, we do try to do the test in a person's first language. We do use interpreters as well. So we try to do that as well. We're not necessarily relying on the family, because sometimes there may be family dynamics that might come into play. So we do like to use an interpreter to get an impartial view as much as possible. We do find, I suppose, in terms of referral rates, that some of those backgrounds of different ethnicities may be underrepresented, because a lot of culturally tend to keep things within the family and they don't always come to our attention. So I suppose are probably underrepresented. So yes, I think they don't always come. We don't get a lot of referrals that way.
No.
But we do, we do where we can, sort of try to acknowledge different cultures and languages and see how we can best, because obviously getting someone to do a cognitive exam which is in English, they're already at a disadvantage. So obviously we're very aware of that. So we do take that into consideration. And I can't remember the rest of your question, so sorry.
Signpost as well is only appropriate.
Yeah, my other question was really what you say in terms of services, because again, this can be, I don't know how it has been reaching out or supported or incorporated, because again, it's making awareness, talking to people and, giving sort of resources, reaching out, because I think it's always difficult. So I just wonder whether you're thinking within the commissioning and all that whether because there are groups and people, but whether they are done in a sort of a way or sort of, I don't know whether you think there are different ways of, doing it, so that could help you not only, make people aware within the community, but also, some of the groups, because we don't have, like if I had to join any sort of culturally groups or anything, there isn't a lot of things that I could attend or mom could attend, sort of thing. So you have to really left to the quite a lot of family. So I wonder whether this sort of things can be thought through in the commissioning, sort of providing within the voluntary sector sort of thing. I should have introduced myself, but I'm a Catering General, the West governor. So, that's, I didn't say, but that's that's how I come to know about. So anyway, so that's really my interest was as first-hand experience of my mom. And I don't know whether there's you use whether past people, how they can, continue involving them.
Francis, I think Francis can answer that.
I'll try to answer some of that. I mean, certainly we do see people of a wide range of cultures reflected in the local area. But as Emma said, I think sometimes people don't get to us. But just recently, for example, a chap who lived most of his life in the West Indies has just been diagnosed. So we're sort of making connections internally with the her advice really on culturally what is available to be able to sort of give an equal service, really. And also the voluntary sector. So we certainly try to find where in people's local areas, for example, there's the Bangladeshi centre in Semalong in Northampton, and made connections with them for some people. And what we didn't maybe say was we also see people with memory problems who perhaps don't have dementia. We see a lot of people that don't have dementia, but we do signpost people to services in their community, particularly educationally, thinking about things like vascular dementia risks, connecting people with health information. And as part of these hubs that are being set up, there's some talks which are provided by a lady from the Open University, it's sort of preventative talks around health, and it's certainly a question we could raise in terms of has there been thought to making sure they're accessible to people from different cultures. So that's more work to do, I think.
Thanks.
Absolutely. Thank you, Francis. Right, I'm going to move on to Tracy's question, because Tracy's been waiting quite patiently. Tracy, did you want to put a question forward or make a comment, please?
Yes, it just it occurred to me as I was listening to your presentation that you may or may not be aware that the soap Hollyoaks has done a storyline on a young person with dementia. So I was sort of wondering, are you aware of that, and does that encourage people to come forward and ask more questions? And is it helpful when these sort of storylines are done? I think the actor's supposed to be in his 40s, I think, and in the storyline. I wasn't sure if you were aware that storyline is on currently.
I don't watch it, but I do think these. I do remember when they did one in Emmerdale. I think they had a younger person there. I'm sure it was Emmerdale.
Yeah.
And I do think it takes away that fear a little bit, because it's more open, isn't it? It's not something, and it's talked about now more.
Another example which had a local connection with, some of you might have seen, there was a programme with the lady from Line of Duty.
Singing,
so it was looking at it was a dementia choir, but off the back of that, the Wellingborough Gospel Choir, a lady, the director of that, was so moved. She said, we've got to do something like this, and actually that, I think, showed a really good range of people. It had some younger people, it had a chat with familial Alzheimer's. So there's a really thriving choir that meets in Wellingborough. The gospel choir support people to attend. They adapted to Zoom during COVID, but they're now back they meet in the quite a modern church. They have cafe facilities. So that was an example of people sort of seeing it. And I've certainly had conversations with people where they said, oh, I saw that programme and I didn't realise that younger people had. So we'll have to watch Hollyoaks.
Thanks, Tracy.
Absolutely, thanks for letting us know about that.
I think I'm showing what I watch on TV now, aren't I?
Yes, absolutely. Giving us a bit of an insight there, definitely. Can I ask Jolene if she'd like to ask her question or make a comment? Over to you, Jolene.
Thank you. Hiya, everybody. Thank you for that presentation. It's really, really good. I was just thinking, because I work for the older adults memory assessment, it's a little bit different. In terms of when you have done your kind of medication treatment, do you have a memory monitoring clinic so the patients can come back and be monitored yearly?
No, we don't. We do all of that, which is so what happens is, does anyone else want to say? No. Okay. So what happens is, if we give a diagnosis, we tend to give the diagnosis ourselves, because we don't have a consultant that works with the team. It'd be nice if we did. It'd be lovely, but hopefully future. But we do our own diagnosing. So therefore, we will contact the consultant to ask for the prescriptions, and we do that for the first 3 months, obviously the same as you do. And then whereas you hand over to another team, we keep people. So our services, it's like we try to do it on need rather than diagnosis. So obviously within the NICE guidelines, we continue to monitor people that are on cognitive enhancer, but we don't really discharge anyone when there's a need. Obviously, when they reach the age of 65, we do hand over if we can, if things are settled. It depends on where we are when we get to that age. But we don't hand over. So with the memory monitoring team and the long-term team is just us. That's it.
Okay. So if you have somebody that you feel is really quite risky, so in the memory assessment older adult, we can then transfer to a CMHT. What would you do if you felt that you had kind of a really risky patient that took up a lot of time? Would you deal with that as well?
We deal with it ourselves, yeah. So we care coordinate. So myself, Emma and Nina, we care coordinate. Francis care coordinates people as well. So we do have people that obviously with younger people that can present as quite a risk. Mm-hmm. I've worked recently with Wellingborough Police because there's been quite a few concerns with people taking advantage and things, because obviously people that are younger, you wouldn't necessarily think they've got a dementia. You know, it can be other things. And obviously trying to do some work with the police as well. So when the police are called to people, they don't first think that they're drunk or they're this or that. Do you know what I mean? So trying to raise the awareness there. But yeah, we tend to do the care ourselves really as much as we can within the team. We use voluntary sector, we use
thinking with the wards
community
well,
mental health teams.
If people are really risky and we felt they weren't safe to be managed at home, I think the difficulties with our age group, I think we don't use the crisis team a lot really historically, but they are an option obviously. But we would make sure we've got a robust risk assessment that incorporates ourselves, third-party sectors, you know, family, friends and all that sort of thing. So we'd be having discussions about managing this safely. But if somebody obviously that escalated, we would be looking at the same kind of things as you do about doing an admission to the ward. So yeah, we would
same process really.
A safe place if we needed to.
Thank you, it's really helpful.
Thanks for that question, Jolene. A great question. Chris, can I hand over to you for your question, please?
Yes, thank you, Fiona. If I may, two questions, but I'll preface that with a reflection and a comment, if I may. Earlier in my NHS career, I managed a specialist rehabilitation hospital where I was hospital manager, and I understand the importance of neuropsychology, Hina. So thank you for the work that you were conveying as part of the team. And I think that also would be part of my reflection, is that very much what has come over is this is a multidisciplinary team approach, that you offer tailored support, that it provides not just support but assessment, that what is clear and very loud, if you like, is the fact that you're having difficult, sometimes tragic conversations with people and supporting them, their carers, their families, people who have lost their independence, their dignity. And these must be very difficult conversations you're having. So thank you for what you are doing, not just today, but every day. And I think it's very humbling. Certainly I felt very humbled by the work that you do. I feel proud to be associated with NHFT, that this is a service that is being provided and doesn't always perhaps enjoy the profile it should do. So thank you from the bottom of my heart. Thank you.
Thank you. That's really kind. Thank you.
A couple of questions, if I may. One is building really on Rashmakant's, and I hope I've pronounced your name right, Rashmakant, is around that unmet need. Because I think you said in one of your slides that over the last 18 months, you've had 417 referrals. Because of my background in this, I did a little bit of homework, as you'd expect, and I think from what I've read, there are just under 1 million people in the UK with dementia at the present time, 42,000 of which are under 65, 5.2% of the total. 1 in 3 people, and this is for the whole group, another reflection, 1 in 3 people born in the UK this year will develop dementia in their lifetime, which means that we'll have over 1 million people by 2030 and 1.6 million by 2050 with people with dementia. And I understand the great work that you're doing for the under 65, as you call young. Is there still an unmet need that we're not supporting? And my second question, and I'm sorry, it is, forgive my ignorance, what do we do for the over 65s who clearly the need, from what I can see from the statistics and evidence, is even a greater need for support as people get older? So thank you again. A couple of reflections and comments, but I think, yeah, 2 questions. Is there an unmet need in the under 65s? Secondly, what happens when you tip over, as a previous member of staff was saying, into the over 65 group? Thank you.
Okay, does anyone want to answer the first one? About the lack of support?
No, it's more, I think the unmet need, if I may, Jen.
Unmet need.
No, just, it's very good. Sorry, just qualify that a bit. Is that what also came over? 2 things. First of all, the co-production, the co-design with service users, which is a golden thread that runs through NHFT in all of its services, is the involvement of service users, and that's really positive. And also the involvement of Northants carers and Alzheimer's groups. Northants carers are one of our partner governors. We work very closely with them anyway. And that's good to see, because at the end of the day, you can't do it on your own. You can't do it, you need the support. And so 2 questions. One was about the unmet need in the under 65 group.
Okay.
And what happens when people tip over the age into the older category, where there's clearly, on the evidence, a much higher level of health burden.
I don't know necessarily if this is something which we can do anything about, if I'm honest with you, but I think we'd all say that a lot of things that carers and relatives will say that are unmet are like respite beds for people under 65, or having adequate places for them to go. So, a lot of people won't want to send somebody who's 55 to a home for respite where the majority of patients are 30. So, and I'm not saying that's something that we can change, but I think that's quite a big one that we come across of the time, to be honest with you. And again, social care are very good, but sometimes when you're asking to speak to them, they don't quite understand. Well, they do understand, but it's almost like you're trying to say to them, you've got a 55-year-old person that needs carers, and then they're trying to throw it back onto a mental health need. And you say, no, it's not a mental health need, it's because of their cognitive disorder. So we do have, that's not something which I think we can do much about.
We do try to, though. We do meet with different services and try to talk about what our service users need, because they've got a very...
Jenny, sorry to cut in, I'm a bit rude.
That's all right.
We can, as governors, we represent, you have staff governors. One of our partner governors is from the West Northamptonshire Council. Now, this is one of the benefits. As governors, we have a foot in the NHS, but a foot in the community. And there is, and I know you can see it, it's that, there is a real problem at times. There's no reflection on individuals in social care. No. But the processes and systems are such that the patient is left in the middle. And if we can help represent you and make representations on your behalf, we can. So I'll leave that thought with you.
Thank you.
We have a number of governors here, both from NHFT, KGH. We can make representations on your behalf if it is about a gap in service delivery. Thank you.
Thank you.
Sorry again.
Okay.
Sorry, your second question.
Yeah.
It's about the over 65s. Yeah. Francis, did you want to say?
Yeah. I think obviously I've not worked in those services, but certainly aware with the different models in that we sort of continue to work, and I think from the pressure of referrals, the older people services are much more sort of focused on the diagnosis and then the annual monitoring. But I think that is the hope with this hub model, that those services will be more accessible and earlier on. And I think things like scanning and other things actually being on site, I don't know if that's started yet. There's discussions about that, so that people almost go and get all the bits early on, and hopefully this would be in some ways parallel with our service. But I think people, certainly from the older services, I think sometimes have had the experience where you wait for one part and then the other part. But then in terms of the follow-up, that being actually almost like little communities, so people in their local area being able to meet continually, because that's also the feedback we get. People say, this is really good, we don't want it to stop, but we don't have the resources to carry on sort of, you know, on a sort of support level that intensely. So I think it seems to me it's quite hopeful that if these hubs are established and that they can recruit to them. I think that's one of the pressures at the moment, actually getting the staff to be able to run these things, and that might bridge some of that gap. And also I think for people we support, it is always considered when they become 65, because some people might receive their diagnosis when they're 64 and 10 months, so we won't suddenly say there you go. But yeah, I think these are going to be challenges, and particularly with the growing population, as you said, the sort of amount of people receiving diagnosis.
Thank you. I see Rashmi's got his hand up again. Chris, is that an old hand or is that a new hand? I'm just aware that we're in the last few moments.
It is a new hand, but I'll let Rash go first. If that's...
Thank you. Rashmi.
Yeah, I just want to say thank you to Chris. He pronounced my name okay. Yes, and another thing is that I do agree with Chris. I think we need to work together. It's not about you can do everything, but it's us governors, community, voluntary stakeholder. The only way we can meet and improve. So I think we're here to help you, but I think it is like have some influence in us, different governors, community coming together. That was just a comment that we can help to work here. I know you can't do on your own everything, but the way we can influence, and you know. So that's all I wanted to make a comment on Chris, what he said. Thank you, Chris.
Thank you so much. Chris, do you want to have the final word before I bring everything to a close?
Yeah, thank you, Fiona. Yeah, thank you, Rashmi. Just a thought, as well as the opportunity for us to make representations on your behalf, it might be helpful if you could let Fiona know where these 8 dementia hubs are. I'm delighted that Corby was the pilot, which I represent in the north of the county. If we could find out where these hubs are when they're open, as governors, we could, you know, pay a visit just to offer some support in, you know, and just to say, you know, because we do represent members of the public as well as members. So please, if you could perhaps let Fiona know, and she could circulate to the governors for both trusts, we can hopefully help you on this journey. And thank you again for all that shared today. Thank you.
Thanks, Chris. So just in these closing moments, I just wanted to say a huge thank you again to Rashmi, I see that you've got your hand up.
Oh, sorry.
Back in.
No.
Okay, bless you. So just a big thank you to Jenny, Emma, Nina, Hina and Francis for a really, really, really informative presentation. Also some great answers to some great questions, and a big thank you to all of you for your attention, your participation, making this a really great event, and a big thank you to Tracy and Nikki who've helped behind the scenes to make this happen. We have we're sharing some of our membership events with our colleagues in KGH. Anybody that's interested, KGH are running a similar membership webinar tomorrow, all about long COVID at 2 p.m. I think I might actually find out about that a little bit myself, because that does seem to be something that I do have a couple of friends that are suffering with at the moment. And our next one is on volunteering and volunteers, which is on the 7th of June, again at 2 p.m. So
sorry, can I just interrupt? The KGH event is tomorrow 6 to 7:30.
I've just been told actually that that it's 6 p.m. So I do apologise. Thank you very much for letting me know, and that'll definitely mean that I can attend that because I won't be hopefully working at that time. So without any further ado, I'm really keen. Well, we are really keen to get your feedback on this. It's the first one that we've done. Our members helped us choose these topics. We've tried to be responsive to what people want to know about. If there's anything that you think we can do better, a subject that you might want us to cover in the future, please let us know. We will be really, really interested in your feedback. We'll be working with our comms colleagues to put this recording up in the next few days, and we'll also put the slides up, which has some very useful information right at the very end, just on some sort of further links of where you might go to for further information and support. But I just wanted to round off today. Great start, Jenny and the team. Thank you very much to all of you for making this such a big success. I certainly have learned a lot more and really thoroughly enjoyed this presentation. So thank you very much. Thank you.
Thank you very much. Thank you. Thank you for everyone joining us.